Welcome back, everyone. Now we'll discuss about headache. The most important thing is differential diagnosis of headache. There are different types of headache: tension, cluster, migraine, medication overused headache. There are other types such as abscess causing the headache, meningitis associated with headache and neck pain. There can be pulsating headache where idiopathic intracranial hypertension is one of the most important cause. But I'll tell you how to identify the headache based on the question. This is very easy. Tension headache, males have most of the tensions, but tension headache usually develops in female according to USMLE step 2. And tension headache is a band-like headache. Tension headache radiates to the back and to the neck. Tension headache usually have pressure in the trapezius muscle. Tension headache is bilateral. Tension headache can be worsened by doing the work. Tension headache usually happens to be in patients who are working. Tension headache, you will have to make sure that acetaminophen must be given. Remember, first you'll have to try paracetamol for the headache treatment. Then you can go for any other medications. Next, we talk about migraine. Migraine, the most important thing you will have to remember is unilateral headache associated with photophobia, associated with nausea, vomiting. Most important thing for migraine. Females are usually affected. Females, childbearing age, females on OCPs, females with pregnancy, where pregnancy can aggravate migraine. Migraine is one of the most important thing. Some patients will have disabling features. Patients have got strict unilateral headache, but this headache usually can develop into bilateral headache as well. The patient describes that it is a pulsating headache. Duration is not specific and can be for 4 hours or can be up to 3 to 4 days. Very important. The most important treatment for migraine is acute attacks of migraine is usually treated with triptans. But what is the contraindication for triptan? Coronary heart disease is the most important thing you will have to remember. Or patient has got arteriopathy. You will have to remember this. In the past, migraine is also treated by ergot alkaloids. Ergot alkaloids has got severe vasoconstriction and can predispose to coronary artery disease. But now migraine, but now for the management of migraine, ergot alkaloids are rarely used. What is the most important thing we use for migraine? We use CGRP antagonist, that is calcitonin gene related peptide antagonist. Very important. This is a new treatment. You'll have to remember this for USMLE step 2. And the next most important thing you'll have to remember for the treatment of migraine is Botox injections. Chronic migraine patients will be treated with Botox injections. Chronic migraine patients can also be treated with the greater occipital nerve injections, where we use lidocaine and adrenaline. Very important. This cannot be asked in the USMLE step 2, but you will have to think of Botox whenever you find migraine or chronic migraine. This is for candidates who are aiming to score more than 275. Next, we talk about the cluster headache. The cluster headache is classic, appears in clusters, and cluster headache, there will be periorbital pain, there will be lacrimation, there will be discharge from the nose, that is rhinorrhea, and there can be associated pupillary abnormalities such as Horner syndrome as well. Next, we talk about the quality of cluster headache. Usually, it happens to be appearing multiple times, and usually it presents for I would say 45 minutes is what in the question they would say. But remember, it can also be present for 1.5 hours. But the most important thing is patient has got episodes and can happen multiple times a day. Most important treatment is 100% oxygen. And calcium channel blockers can also be used for prophylaxis. I missed about the prophylaxis for migraine. For migraine, calcium channel blockers can also be used, topiramate can also be used, and beta blockers can also be used for prophylaxis of migraine. Whereas for cluster headache, calcium channel blockers are used for prophylaxis of cluster headache. Next, we talk about analgesic overuse headache. Analgesic overuse headache, I would say rule of three. Patient using medications for more than 3 months, more than three times a day for the headache causes analgesic overuse headache, also called as medication overuse headache. Patient has classic presentation where headache is usually resolved after taking the medication and starts after the medication effect weans off, and then it happens to be a dull headache, round band like headache always present, and there will not be any response to the medication. After that, what is the treatment for analgesic overuse headache? You will have to stop analgesics. Remember, some of the physicians prescribe opioids. This is not for USMLE, but this is for your lifetime practice. Opioids do not work for headache, please. Very important. I see physicians giving morphine. No. I see physicians giving cocodamol. No, please do not do that. Instead, the patient develop constipation and patient will be irritable after that. So opioids are not used for headache or analgesic overuse headache or any type of headache. Next, we talk about thunderclap headache. Thunderclap headache is nothing but sudden severe headache, usually the worst type of headache. And in thunderclap headache, the severity goes from 0 to 10 within less than 5 minutes. That is what you call it as thunderclap headache. And remember, in thunderclap headache, I want you to remember the most important differentials. Subarachnoid hemorrhage, you can also think of cortical sinus venous thrombosis. You can also think of reversible cerebral vasoconstriction syndrome. Remember, whenever you find this thunderclap headache, you will have to think of all the differential diagnosis. Talking about subarachnoid hemorrhage, the patient usually has got occipital headache, patient usually has got neck pain. Patient, the diagnosis of subarachnoid hemorrhage is usually a CT scan within less than 6 hours, please, very important. And lumbar puncture needs to be done only after 12 hours. Why is this? Because in lumbar puncture, we are specifically testing for xanthochromia. Whenever we are testing for xanthochromia, after 12 hours, the pathophysiology of testing xanthochromia is to identify the bilirubin oxidase activity. Remember, bilirubin oxidase activity is only active in the body. Bilirubin oxidase activity is not present in vitro or in the lab. That is why we test xanthochromia in the CSF after 12 hours, because bilirubin oxidase takes time to work and there will be xanthochromia formed only after 12 hours, and that too it will be formed only in the CSF as in vivo. There is no in vitro activity of bilirubin oxidase. Very important, please. Next, subarachnoid hemorrhage, when it causes raised intracranial pressure and mass compression or midline deviation, you will have to treat with surgery. Meningitis, itis of the meninges, fever, headache, neck pain, nuchal rigidity. There can be fever and there can be bilateral involvement of the headache. The most important treatment for meningitis is ceftriaxone. Next, we talk about headache secondary to abscess. Again, headache secondary to abscess is fever and presence of neurological symptoms. Depending on the position where the abscess is present, there will be neurological dysfunction or neurological symptoms. I want you to understand that Abscess can also cause rise in intracranial pressure and can present with projectile vomiting. Fever with projectile vomiting, you think of abscess, and abscess, the treatment is ceftriaxone again. Next, we talk about tumor. The most important thing I want you to understand whenever you are dealing with a patient with tumors of the brain or change in the character of the headache. Initially, the patient will be having dull headache, and now the character of the headache that is changed from dull to constant headache is characteristic of tumors. Tumors can be present in middle age, young age, and elderly. But how do you differentiate that the patient has got a tumor or patient has got headache associated with tumor? It is because of the change in the character of the headache. And remember, whenever there is metastasis to the brain, there will be involvement of the gray white matter junction. Metastases are usually predisposed or present at gray white matter junction. Whenever you think of tumor, the most important and initial investigation is CT scan. Remember, initial investigation is CT scan. The confirmatory investigation is the MR scan. In order to diagnose what type of tumor, it is the biopsy that we do. But in rare cases, the biopsy is performed. Talking about the tumors, I also want you to understand whenever there is tumor, there will be increase in the intracranial pressure. Patient presents with eye symptoms, papilledema. There will be headache, there will be raised intracranial pressure. Nausea and vomiting are the most important features that can be present. I also want you to understand whenever there is headache, secondary to trauma or secondary to tumor, there will be associated papilledema, and papilledema is one of the most important clinical examination findings in tumors. You will have to do a formal ophthalmology assessment as the next best step in order to identify the visual field abnormalities the patient has got. You'll have to remember this scenario because this can be asked in the exam. Tumors presence tumor brain tumors usually cause compression of the optic nerve that causes papilledema. There is this syndrome called Foster Kennedy syndrome where patient will have frontal lobe tumor, and in the frontal lobe tumor there will be compression of optic nerve. Whenever there is compression of the optic nerve, the patient will have ipsilateral papilledema, ipsilateral optic atrophy and contralateral papilledema. Ipsilateral optic atrophy and contralateral papilledema, you'll have to think of Foster Kennedy syndrome. Characteristic of frontal lobe tumors. I want you to understand this. Next, we talk about one of the most important differential diagnosis of headache is idiopathic intracranial headache. Whenever there is idiopathic intracranial headache, there will be increase in the pressure. Whenever there is increase in the pressure, again, nausea, vomiting, headache, projectile vomiting. But I want you to identify this in the question saying that a young age women, young age female patient or obese patient or patient with pregnancy or patient with history of stroke, patient with history of oral contraceptive, patient with history of vitamin A overdose has the features of intracranial hypertension. Whenever there is intracranial hypertension, the features are headache will be worsening with waking up. Headache will be worsening on coughing. The most important diagnosis you'll have to do for idiopathic intracranial hypertension is to identify the rise in the pressure. How do you identify it? It is by the lumbar puncture, checking the opening pressure. That is how you diagnose idiopathic intracranial hypertension. The treatment for idiopathic intracranial hypertension is lifestyle modification. Reduction of the weight plays an important role and is the first step in the management of idiopathic intracranial hypertension. Remember, whenever there is idiopathic intracranial hypertension and whenever you have the option of weight or lifestyle modifications, please do select that as a first investigation of choice. Next, the patient can also use acetazolamide. Remember, pregnant patients must not be prescribed acetazolamide. Next, whenever the patient is not responding to acetazolamide and lifestyle modifications, serial lumbar punctures must be done. That's the most important and takeaway points for this headache. Next, we talk about the types of headache. We talked about types of headache. I also want you to understand there are some warning signs of headache. First, most important warning sign is I want you to understand that the change in the character of headache is the most important warning sign. Also, remember whenever there is headache associated with seizures, you will have to think of hemorrhage. Yesterday, we discussed that change in consciousness, altered consciousness, decreased consciousness points out towards hemorrhagic stroke. Whenever there is hemorrhagic stroke, again, there will be increase in intracranial pressure and change in the intracranial pressure symptoms as well. Remember, the warning signs of headache can also be the change in the headache, change in the character of the headache, the frequency of the headache as well. Whenever there is headache in the elderly patient, that is a warning sign that is suggestive of brain tumor. I also want you to understand the most important surgical question tested in USMLE step 2 is glioblastoma multiforme. Whenever there is glioblastoma multiforme patient can be middle-aged, patient can be having headache, patient can be presenting with weakness, and patient can be presenting with loss of consciousness or change in the behavioral pattern as well. On the MR scan, you find that glioblastoma multiforme is got multiple formations of the tumor and there can be associated edema as well. Very important. Next, we talk about red eye. The most important red eye is acute angle closure glaucoma. Acute angle closure glaucoma in the USMLE step 2 question, patient will be using anticholinergics or patient will be using decongestants. And this acute angle closure glaucoma will have rapid onset of eye pain and there will be presence of halos. There will be mid-dilated pupil. I want you to understand this. And this mid-dilated pupil will be poorly responsive to light. Whenever you do not treat patients with acute angle closure glaucoma, there can be sudden visual loss as well. Fundoscopy you will have to do, and on fundoscopy you will find there is cupping of the optic disc. Other features you find in acute angle closure glaucoma or the congestion of the conjunctiva, there can be corneal edema, or there can be corneal cloudiness. And the pupil is the most important finding. You will have to search in the question where there is fixed and mid dilated pupil. The cupping of the optic disc when we do an ophthalmoscopy examination, there will be enlarged cup with a ratio of more than 0.6. The ratio is measured between cup and the disc, and there can be thinning of the optic disc as well. Whenever there is glaucoma, whenever there is enlarged cup, remember there is also optic nerve atrophy. So there can be pale disc as well. Next, we talk about giant cell arteritis. I want you to understand in the question, it's a 65-year-old male patient or female patient who presents with headache, who presents with jaw claudication, who has got a history of polymyalgia rheumatica, and the patient can also present with fatigue, malaise, weight loss, and on clinical examination, the most important thing you find is tenderness over the temporal regions. Tenderness over the mandibular region is temporomandibular joint dysfunction. Tenderness over the temporal region is giant cell arteritis. This is a clinical examination finding. On the laboratory test, you will find increase in ESR. First, most important step is start the patient on high dose of glucocorticoids, that is 60 mg of glucocorticoids that must be done, and this is to be started whenever you think of giant cell arteritis and whenever you've got high suspicion of giant cell arteritis. Next we talk about the complication of giant cell arteritis. This can cause visual loss That is why you will have to start the patient with high dose oral glucocorticoids. Remember, in the question, you will find that the patient has got increasing age, history of polymyalgia rheumatica, and most importantly, there will be increased ESR as well. That is when you diagnose giant cell arteritis. Next, talking about polymyalgia rheumatica, there will be algia in the muscles, which is poly, that is many muscles are involved or many group muscles are involved. Patient usually have got normal muscle power in polymyalgia rheumatica, but there will be increased ESR, but there is no damage to the muscles, so there will not be any rise in the CK. The treatment of polymyalgia rheumatica is glucocorticoids. Next, we talk about one of the most important differential diagnosis of a stroke, that is hemiplegic stroke, usually seen in female patients, usually seen in young patients with history of migraine, where the patient develops unilateral hemiplegia, which usually resolves within few weeks. This is diagnosis of hemiplegic migraine. Patient presents with headache, patient presents with hemiplegia. CT scan will be normal, MRI will be normal, and CT angio will also be normal. That is the diagnosis of hemiplegic migraine. Remember, hemiplegic migraine is best diagnosed on history taking. So, history and clinical examination, that is complete history and clinical examination, is what you will have to choose when you find an option like that. Next, we talk about another type of migraine where it is also a stroke mimic, but it is very less common in USMLE step 2 CK. That is basilar migraine. Whenever the basilar part of the brain is involved or the posterior part of the brain is involved, patient usually have headache, vertigo, dysarthria, and there can be loss of balance as well. Whenever patient has got migraine, the symptoms usually present for 3 hours and then resolve. That is diagnosis of basilar migraine. We talked about intracranial hypertension as well. I'll see you in the next link. We'll discuss more about epilepsy, subarachnoid hemorrhage, cerebral abscess, and cerebral sinus venous thrombosis. Thanks very much.